Hey everybody, I'm John Draper. I'm President of Research Development and Government Solutions at Behavioral Health Link. And I'm here to talk to you today about something we don't often talk about, but perhaps we can start by just remembering a time when we were going through something rough. And we talked with somebody we care about, and we shared with them what was happening with us, and they gave us some help, and it felt good. And then maybe a day or two or a week later, you get a text or a phone call from them, which is simply just thinking about you, how you doing? And just remember how you felt when you heard back from them. And that's what we call a caring contact, or what we would also call follow-up care. And it's not something that is often talked about in our work in crisis care. We often talk about someone to talk to when we're in crisis, reaching out. We reach out to somebody when we are feeling like we need to talk, like a crisis hotline, or maybe someone to come to us when we can't reach out. Somebody has to reach out to us and come to us into our home because we can't leave our home for whatever reason. Or a safe place to go if we need to go to some place safe so we don't get hurt or hurt ourselves. Just stay for a night, perhaps in a crisis receiving facility in the community. But we don't hear much about that other, perhaps fourth pillar, which is often recommended in suicide prevention and crisis care, but rarely talked about. Now, it is recommended in many places. So most recently, we saw in SAMHSA's 2025 National Guidelines for Behavioral Health Coordinated System of Crisis Care, coming out in early 2025, what they said here, and this is actually something I had brought up. I was one of many advisors to this document. And one of the things I suggested to them, I said, we talk about someone to talk to, someone to respond, and somewhere to go, but what about someone to follow up? And they said, we don't want to make that a fourth pillar because we want it to be a part of every pillar. It needs to be a part of the entire crisis continuum. We should be following up after a crisis call or after a crisis contact with mobile crisis or after we've been discharged. So we want to make it a part of everything. My only concern is that if we don't make it a fourth pillar and we don't put it front and center, it becomes an afterthought because it's what happens after a contact. And it's not often funded. And so it's not often the primary focus of making that first contact. So it is suggested, though, in many other places in crisis care. The National Strategy for Suicide Prevention in 2024 also mentions it at various points throughout the entire document, but on Objective 9.4, they want to make sure that we follow up for people at risk of suicide along the entire crisis care continuum, which again is echoed in the 2025 SAMHSA standards. But in the standards that were put out by the National Action Alliance for Suicide Prevention, I think it was around 2019 that they put this out for all healthcare facilities. They said, look, if you are going to be working with somebody who is suicidal, you need to do these four things. And one of those four things that they said you've got to do is doing follow-up contacts. And they compared it, I thought, very reasonably to heart disease prevention, the number one cause of death. Right now, a very standard, routine thing that you do, and I'm certainly on statins, is anybody who could in one way be at risk because of their age or whatever reason, if they've had prior diagnosis, they should be taking statins every day because that reduces your chances of heart disease by 30%. Actually, we found out that follow-up care reduces your risk of suicide even more so. So it should be absolutely standard. The Joint Commission also agreed to the National Patient Safety Goals in 2019 when they said, look, if you're working with somebody who's suicidal and they are in your care in a hospital, upon their discharge, you have got to do follow-up contacts. Now, we've also seen it on CBS Sunday Morning. I thought this was a fantastic segment. It was done in 2020. If you want to check it out, it's on YouTube, where they talked about the importance of caring letters and follow-up contacts in reducing suicides. And I think it was around 2018 when I was in Portland, and I was there for a conference, and I was not feeling well. I don't know, maybe I had the flu or something, and I said, I've got to go to urgent care. So I went to that facility. They took good care of me. They were very polite, very efficient. And then a year later or so, on my birthday, I get this text, and I get this every year. on my birthday. And it says text stop to unsubscribe. Are you kidding me? I am not going to unsubscribe. I mean, it's so reliable. It's so nice. I count on getting these every birthday. It's also perhaps some reliable than some of the people who love me. But anyway, what is the goal of follow-up? And how does it happen? Well, it happens and can happen in many different ways. It can happen by in-person home visits, or carrying phone calls, or carrying texts, or carrying letters and postcards. And it's always designed to do these kinds of things. We want to make sure that you're feeling better, less distressed, and that if you've been presenting with any level of risk, we want to reduce that risk through these caring contacts. And if you've been recommended to, or referred to care, we want to make sure that you are connected to care. But why is it recommended for suicide prevention and crisis care? It's pretty pervasive in terms of its recommendations, but why? Let's start with the origin of follow-up. Who came up with this idea? A guy named Jerome Motto, back in World War II, was serving time overseas near the front lines in Belgium. And he was really feeling terrible every day. He was frightened. He was being, as many people were, totally exposed to very, very difficult things, and was trying to keep his head on straight. And one of the things that really helped is letters that he would receive from people back home. Now, yes, his family letters were sometimes good and sometimes not, but what was always good for him were these letters he got from a woman named Marilyn. Now, Marilyn was somebody he knew kind of well, not real well. They had been on maybe a half a dozen dates. And, he didn't fancy her, so to speak, but they were very friendly. But she just started writing him. And what she wrote him up, these were not romantic letters. They were very mundane. They were basically letters that were just talking about how life was back home. They just built a new Sears and Roebuck downtown, or the basketball team is doing fantastic. And he came to cherish these notes from Marilyn that, again, were not romantic, but after a while, what they were doing for him is, in all this chaos and scary, terrifying, fearful situation that he was in, was reminding him of something normal, where there was peace and calm, and people were thinking about him from that place, and extended to him and connected to him in this very difficult place, and pulled him for a moment back home. And that buffered him in that moment. And he began to think, I really like this Marilyn, and perhaps maybe we should start a romance. And so his letters started to become a little bit more romantic, but not hers. She just continued to write what she usually writes. But they were very sweet and caring, and he thought, well, maybe when I come back to the States, Marilyn and I can get together. Well, that never happened. He did come back, and he and Marilyn never connected. But these letters stayed with him, and they stayed with him when he became a psychiatrist at a hospital in San Francisco and was working with suicidal persons, and was worried about them upon discharge because they were going right back into the community, and some of them ended up coming back, and he would hear that some would die. And he thought, my gosh, these people in many ways remind me of the people that I saw and served with on the front lines in Belgium. And I remember what those letters meant to me and how they were a buffer against that fear and terror and things I didn't want to deal with, but helped me get through. I wonder if we sent caring letters to people who'd been discharged, who'd been suicidal, if that could also be a buffer for them. So from 1969 to 1974, they sent out these letters. And I'll tell you the impact of that in just a minute. But I first want to note how important it was that he selected this population in particular to provide caring letters and follow-up to, because we see post-discharge very high suicide rates from people who've been suicidal, who've been in emergency departments and in inpatient hospitals. Within a year of discharge from emergency departments, we see about a 57 times higher rate of suicide from people who've gone to emergency departments who presented with suicidal behaviors. And anybody who's had suicidal thoughts upon discharge within a year, they have a 31 times higher rate of suicide upon that discharge. Now, at inpatient hospitals, it's even more dramatic. Within the first 3 months of discharge, the first week post-hospitalization, there's a 300-fold increase in the rate of suicides among people compared to the general population. And you take a month out later, it's about 200 times higher, and 3 months later, 100 times higher risk of suicide from people who've been discharged from hospitals. Now, back to Jerome Motto for a moment. Those caring letters reduced suicide by nearly 50% for those people who had received those letters relative to the people who did not for the next 2 years. There was a caring postcard study that was done for emergency departments and people being discharged from that in Iran, and they saw a 3-fold reduction in suicidal ideation, about a 58% reduction in attempts. We've seen also some, but not quite as dramatic, in various studies around text messages post-discharge, some phone calls from post-discharge in France, done in an emergency department. Again, we saw some reductions in risk. But the World Health Organization study, which was really big over 18 months across 5 nations, where they did a mix of some in-person follow-up, but mostly phone calls, showed an 11-fold fewer suicides for those people who were receiving follow-up care. So what is in those written messages? And we're just talking about the written messages for a moment, not the phone calls, but what is in those messages that seems to make a difference? First of all, they're not demanding anything. They're not saying that you have to show up to an appointment or you need to reply in some way. They're non-judgmental. They just say things like, "We hope you're doing well. Just want to let you know that we're thinking of you. Remember that help is here at the hospital and we're here if you need us. Take care." What's also really important is they don't just send you one message. They repeat these messages over increasing intervals of time. The idea there is that, hey, we're not just thinking about you today. We're thinking about you a lot. In fact, some guy remarked after when Jerome Motto started sending out all these letters, that they got 24 letters over 5 years, so that you are a persistent son of a bitch. But they were very, very, I think, impressed by the degree to which people were thinking about them and valued them. Again, in all the studies, these are repeated contacts over a period of time. So with all of this research in hand, the Joint Commission began to ask themselves and thought we should ask our hospitals, are they actually doing the follow-up care that we recommended in our patient safety goals? Oh, less than a third of them were actually doing follow-up contacts. National Action Alliance Suicide Prevention commented on what they knew was not happening and said, this is it's kind of a no-brainer, because in post-surgical and medical procedures, it's absolutely routine to get contacts from them and saying, "Are you okay?" But if you've been suicidal and you've been in a hospital or emergency department, it's not routine. In fact, as you see here, it's not happening most of the time. Now, something that we also have spent a lot of time doing is looking at follow-up following crisis phone calls. And this is, I think, some very meaty research that I had the privilege of being a part of. Originally, working with Dr. Madeline Gould and John Califat in the very first studies to determine whether or not crisis hotlines worked. Just making the phone calls, were those phone calls that people were making reducing their distress and suicidality? And Dr. Gould and Dr. Califat found yes. In fact, it's at the end of the phone call, most of the people are feeling better, and most of them are feeling less suicidal if they were thinking about it to start with. And then when they phoned them up 3 to 4 weeks later to see how they were doing after that phone call, most of them said that they're still doing really well and they're less suicidal. Most of them. There were some that, in fact, 43% were still having recurring thoughts of suicide, and a few that actually attempted suicide. And about a quarter of them who had been recommended to care weren't going. And so Dr. Gould and Dr. Califat said, we're worried about those people. We've got to do something. We've got to follow up. And so they recommended follow-up to the Lifeline and SAMHSA. And so we said whenever the findings from the evaluators told us what we needed to do, we had to do something. And so we would go to our Standards Training and Practices Committee of researchers, experts, trainers, and establish national standards. We would implement them, we would train centers to them, and then we would evaluate them to see whether or not they worked. But it was harder with follow-up because we were having a hard enough time. I mean, our crisis centers weren't even getting paid enough to answer calls, much less to make calls afterwards. So SAMHSA said, we got to do something about this. Dr. Richard McKeon, I think, really spearheaded this work in saying we've got to put out follow-up grants for those centers that want to do follow-up. We're going to give them a structured follow-up program, tie funding to it, and let's get them to do it and then evaluate it to see its impact. And so these started in 2008. And the very first findings for what happens when you follow up for crisis phone calls were produced they were produced in 2017. We got them in 2014 at the Lifeline, but they were stunning. As you can see here, 91% of the people that were receiving these follow-up cares said that these calls kept them safe, but 80% stated the calls in some ways stopped them from killing themselves. About over half of the people said it's the reason I'm alive was because of these calls. Now, it might have been 100% would have said that these made a difference in stopping them from killing themselves, except that about 20% after the first call to the Lifeline didn't really feel terribly suicidal afterwards, even though they agreed to follow up and said, I really haven't been thinking about it since then. So the follow-up calls weren't really helpful because I didn't feel bad. But for those people, and especially the people with the highest risk, people who had had past attempts of suicide, they were the most likely to report these life-saving events. And the callers said that the follow-up helped them feel like there was hope, made them feel cared about, and helped them connect to any further mental health resources that they needed. We also found, and Dr. Gould found in the research, that it wasn't just what happened on the calls, but the more calls that they made, the greater the life-saving impact. So if you get 2 to 3 calls, it improved the odds of reporting these benefits twofold. If you got 4 or more calls, 4 times the odds of reporting these benefits. And the longer the calls, also the greater the benefit. All of this is a message that we're thinking about you, we value you, and we want to spend time with you. And another thing they found that was really important that they did on the calls was reviewing with individuals who had been suicidal their coping strategies. And specifically the Stanley Brown safety plan structure was particularly important. And we'll talk about that in a moment. But again, these are some of the things here you'll see on screen that people said really made a difference about these calls. Essentially, it is, you've been thinking about me, I must be worth something. I mentioned something about safety planning, and I want to talk about because safety planning is talked about all of the time in suicide prevention. It is very commonly pointed to as an evidence-based practice, and you saw that and you've heard the safety plan that was put together by Stanley Brown is kind of standard everywhere, and you've seen probably these if you're interested in suicide prevention that safety planning has got to include getting some sense of what a person's warning signs, what are the triggers that tell you that you might be thinking about suicide or could be at risk. And what can you do internally to take care of, what are the internal coping strategies, things that you can do in the moment to calm yourself, or people that you can contact, can distract you from the crisis, or people who can support you through it, including professionals or agencies that you can contact. And also, how do you keep your environment safe? What's also important and often not talked about enough is also checking on the reasons for living and being able to identify that in the safety planning process, because a person needs to have a reason to feel safe. They need to be reminded that, oh yeah, if I kill myself, it would be devastating for the people I love, or it's just incredibly important, and my life is incredibly meaningful in so many ways. I wouldn't want to endanger that by harming myself. But one of the things that they found, of course, when they discovered that these safety plans can really reduce suicide risk. Well, at least something they don't talk about that much around these findings that say, oh yeah, this works. The reason it works is not just the content of the safety plan and how that itself is useful, but all of the safety planning studies that show it works are done in the context of follow-up. That means that when you're putting together your safety plan with a counselor or a clinician, they don't just hand you that safety plan and say good luck with that. It becomes like most any other piece of paper you walk out of a hospital with. You don't maybe live your life by it. It might end up in the trash. You might forget where you put it. It just simply doesn't become integrated into your lifestyle. It does, however, become integrated in your lifestyle if you're talking about it regularly with somebody who says, let's review your safety plan and see how that's been helpful for you and what hasn't been helpful for you, and are these people still supports that you can rely on? Maybe they're not anymore. How do we update that plan? It has to be a dynamic process, and that happens through follow-up. Yet even though, and I asked Barbara Stanley, the dearly departed Barbara Stanley, about this several years ago. I said, have you ever seen follow-up work with, or safety planning work without follow-up? And she said, no. But again, they focused on the safety plan aspect of it, and that's also what you see with hospitals who did in fact say, thank you, Joint Commission, for giving us these standards that say we should be doing safety planning, and then most of them do it. It's easy to do in the hospital. Let's sit down and do your safety plan. But how many of them were actually doing follow-up contacts, also recommended by the Joint Commission? Not many. So again, most of the time they give you your safety plan in the hospital after you've worked on it with them, and then you leave the hospital, you don't hear from them, and your safety plan isn't useful. So I wonder about call centers and mobile crisis teams. To what extent do they know that follow-up should include safety planning, and safety planning should include follow-up? We know that SAMHSA follow-up grants, which are very limited, they're still happening today, about 10 centers, I believe, getting follow-up grants, but there's over 200 centers in the National Suicide Prevention Lifeline or 988 network. So are they told, or do they understand that if they're doing safety planning on the phone, they need to do follow-up, and if they're doing follow-up, they need to do safety planning? And our mobile crisis teams who are routinely doing follow-up and say they're doing safety planning, do they marry those? Do they review the safety plan on their follow-up contacts? Again, this is not a message we are putting out there, and we need to have structured, consistent follow-up recommendations, and this is why perhaps software and tools need to be developed that underpin this structure that say, okay, let's check on your safety plan every time. Let's, in fact, follow all of the recommendations that are provided by the 988 Lifeline, who put out these guidances based on the research that have been done. They said follow-up contacts really have to start with just checking on the person to make sure they're okay, assessing their well-being and suicide risk, and then collaboratively reviewing and updating the safety plan as needed. And that we need to coordinate the care with them and other providers, and also just make sure that they're properly connected to needed services. But we have to have a clear program of protocols to make sure that we're consistent, because our folks who are doing the follow-up are not always the same people. So you don't want it to be radically different if different people are doing the follow-up. You want the same experience, the experience that we know has been shown by evidence to work, to be carried through with every contact. And that means establishing a safety plan and structuring calls with it. And also tracking and reporting on these outcomes. Now this is what, when I came to BHL a couple of years ago, it was really important for me to work with the IT team, our outstanding IT team who puts together the platform, to build into the DNA these best practices and create a follow-up module that did follow all of the best practices that we have seen make a difference in preventing suicide through the years and years of research. And so this platform module is built around providing, first of all, a summary of the prior contacts. And regardless of who's doing the follow-up, they know what happened previously with this individual that they are now speaking with, perhaps for the first time. So they got a summary of their prior contacts, problems, risks, referrals. They do a brief assessment with them. check on their level of distress, to what degree they might be at risk of harming themselves or other people, and then reviewing and updating their safety plan. Is this still working for you? What's been helpful recently? What can we do to reinforce some of the things that do work, or perhaps replace some of the things that don't work? And then to what degree are you being connected to care? And are there any barriers that you're encountering that I can help you overcome? Let's develop some strategies together. And then also survey with them, ask them, is this helpful for you? Is it reducing your distress? Is it reducing your risk? Is it helping you get connected to care? So we're getting constantly client-centered feedback and really reporting on outcomes that matter. Look, right now we are doing, I think, a pretty good job of talking about how our crisis care services are responsive, at least in terms of how quickly we answer the phone, our average speed of answer, how quickly do our mobile crisis teams respond and get out to people's homes, and basically the kind of efficiency data that helps us get a sense how long people are waiting. And we don't want people to wait at all. But what I think really matters to people is once we actually connect with them on the phone, once they actually start talking with us or we come to their home, do they feel cared for? Do they feel safer? Do they feel less distressed? Are they getting connected to the kind of resources that can keep them feeling safe and less distressed? These are the outcomes that matter, that will tell us whether or not our system is working. And these are the kinds of outcomes that we can routinely collect really only in follow-up after the contacts have initially occurred at the call center level, at the mobile crisis level, or post-discharge. Are you connected to care? How are you feeling? Are you still feeling safe? And these kinds of data will help us get a sense as to where there are cracks, holes, gaps in our system where people are falling through, as well as what's working. Dr. Richard McKeon, who is in many ways the father of follow-up at SAMHSA, really talked about, and he said this just recently on a crisis jam, that follow-up is really a key in suicide prevention, that we see that it works and it must work and it can work if we do it. And we have to do it at every level, whether it's the phone contact or mobile crisis visit or leaving a crisis stabilization, basically saying that we have to stay in contact with people at risk and work with them to reduce suicidal behavior and increase their linkages to care. I really appreciate his words, but when I think about some other words that really I appreciate is a man named Tom Kelly, who's a peer advocate, provide peer support, had been through his own suicidal moments back in 2014 when he was telling us about the follow-up care that he provides as a peer advocate, and it reminded him of how important it was when he received it. And he said that what he gives to people on those follow-up calls is what he got. And that was this belief that I am a person and I am not a lost cause. And I think personally something that I'm very aware of, people contact me as a crisis services professional in my life, my friends, my loved ones, they certainly bring me their problems and their concerns. But when I'm worried about somebody, I always remember I need to follow up with them. And this is something that we can all do. Hey, what can we do? Can I talk with you later this week? Or are you around tomorrow? I just want to check on you to make sure you're okay. We can all do something for follow-up, and we can all do something to keep our loved ones safe, as well as ourselves. Thank you all.